Hello.
So we have Dr. Nadeeja Najeeb with us. She's a DNB graduate. ഇവിടെ കേൾക്കുന്നുണ്ടോ നമ്മള്? Hello, am I audible now?
Yes, Vaishak.
Yeah. So today, good evening. Welcome to another session of toxicology series. We have toxic alcohols today. It's something that we encounter most often in emergency department, but it's far beyond just ethanol intoxication. So today's session is about toxic alcohols, its complications, metabolic acidosis, its withdrawal, and how do we approach with an evidence-based emergency management in alcohol poisoning. So we have Dr. Nadeeja Najeeb with us. She is a DNB graduate from Apollo Hospital, Chennai, and member of Royal College of Emergency Medicine, and currently working in Aster MIMS, Kannur. I would like to invite Dr. Nadeeja to the session, and over to you, Doctor.
Thank you, Dr. Vaishak, for the warm welcome. Good evening, everybody. Hope you are ready for this lecture. So today we are going to discuss about something that is very commonly present in the emergency department. Yes, it is a very dangerous presentation, the intoxicated patient. We know that during every shift, we come across patients who are just labeled as drunk patients. But even though most of them are harmless ethanol intoxicated patients, we do have some people who are having severe withdrawals, have ingested toxic alcohols like methanol and ethylene glycol. Throughout this lecture, I would want you to focus on three important questions. Which alcohol has the patient ingested? What is the appropriate treatment for this alcohol toxicity? And when to escalate the management? So we would recognize the pattern, resuscitate appropriately, and escalate the management. Let's start with a case. During a night shift, a 34-year-old woman has been brought in by the police. She was found agitated and combative outside a nightclub. Her heart rate was 138, BP was 168 over 100, temperature was 39.4, respiratory rate was 24. She was saturating at 97% room air. She was diaphoretic, dilated pupils, and was picking at her clothing. How would you manage this patient before any history is available? If you have been following this lecture series, I'm sure you know how to approach a patient who's intoxicated. An undifferentiated intoxicated patient is like any other patient. The primary management goal is to secure the patient's airway, breathing, and circulation. Make sure to assess the point of care glucose of this patient, check the core temperature, assess for the blood gas analysis, control if there is any severe agitation. This sequence never changes, regardless of which toxin you suspect. Moving on to today's discussion, ethanol toxicity. Ethanol is the most common alcohol which is ingested, and these patients present to our emergency department on a very common basis. Maybe that's why this familiarity is making us have a decision-making bias. So make sure you do not miss any major diagnosis while labeling the patients as just drunk. It is a very dangerous default. You have to make sure you do not miss any of these major diagnoses. Traumatic brain injury is missed while you label the altered mental status on the alcohol intoxication alone. Make sure to do a thorough neurological examination and keep a very low threshold for a CT head. Hypoglycemia is commonly present with alcohol intoxication itself. Make sure to do a point of care glucose examination for all the patients. Sepsis and meningitis can present along with patients having alcohol withdrawal or intoxication. Fever can be attributed to dehydration or to withdrawal. Make sure to look at the vital trends and exam for signs of meningitis. Wernicke's encephalopathy. Classical triad is usually not present. Do not wait for the triad to appear. Start with thiamine if you have any kind of doubt. Even though ethanol is a single molecule, it has two receptor systems. This is the mainstay of treatment, and this is what you have to understand regarding the management of ethanol toxicity. In case of acute intoxication, the ethanol molecule potentiates the inhibitory GABA receptors and inhibits the excitatory NMDA glutamate receptors. That is why during acute intoxications, most patients are sedated and have less activity. Whereas in chronic usage, the GABA receptors are downregulated and the NMDA excitatory receptors are upregulated. That is why in chronic use withdrawal syndromes, most patients have an excitatory symptom. This is the mainstay of treatment of benzodiazepines in chronic use withdrawal syndromes. This is what you have to understand why benzodiazepines are being used as antidotes for withdrawal. 4 hours later, we get a new history that the same patient has been drinking a bottle of wine every night. The last drink was 30 hours ago. She had a single seizure in the bedside, which was self-terminating. Now she is appearing more confused, tremulous, and diaphoretic than on arrival. Now you see, we are dealing with a patient with alcohol withdrawal. Regarding alcohol, the ethanol, which is the most commonly ingested alcohol here, it is metabolized by alcohol dehydrogenase in the body. The level of inebriation is always directly proportional to the concentration of alcohol ingested. Let's look at a predictable timeline. During the early withdrawal symptoms, around 6 to 12 hours from the last drink, patients would have tremor, anxiety, diaphoresis, and tachycardia. After 12 to 24 hours, patients might start to have hallucinations, which can be visual or tactile. After 1 to 2 days, the withdrawal seizures can settle in, can be generalized, usually single, and early in onset. 2 to 3 days later, the most riskiest of them all, delirium tremens sets in, which has disorientation and autonomic storm. You have to keep in mind that even though there is a timeline, the withdrawal does not go by the book. This is just a guide for you to use. You have to treat the symptom which is in front of you. And one more thing regarding withdrawal is not only when the patient has stopped taking alcohol, it is also occurring when the patient has reduced the quantity or the concentration of the alcohol which he usually takes. The most important tool which would help you in grading the severity of alcohol withdrawal is the SIVAR scoring. SIVAR scoring is a clinical institute withdrawal assessment of alcohol revised score. You do not have to mug up the score. This is available in all your online platforms, all your online calculators. You just have to understand how this works. According to SIVAR scoring, there are 10 domains of scoring. These 10 domains are scored according to their severity, and a total score is summed up. If the score is less than 10, the withdrawal is termed as very mild. If it is 10 to 15, it is mild. If it is 16 to 20, it is modest. If it is more than 20, it is severe withdrawal. What do you think is the disadvantage of having the SIVAR scoring? Do you think it is practical to do the SIVAR scoring in all patients? No, it's not. If the patient is very combative, highly sedated, if the patient is intubated, you cannot use the SIVAR score. That is where your clinical gestalt comes to play. How do you treat this alcohol withdrawal? As I mentioned, you have to assess the SIVAR score wherever it is possible, or use your clinical gestalt to grade the severity of the alcohol withdrawal. If the score comes to more than 8 to 10, treat with benzodiazepine. Choose a longer acting benzodiazepine like diazepam or chlordiazepoxide and titrate according to the sedation necessity. You have to reassess the patient very frequently and redose. If you are requiring higher doses of benzodiazepine, choose phenobarbital additional to the benzodiazepine. We'll talk about it later. Why do we use diazepam here? Diazepam has a very long half-life and active metabolites, so it's easier to titrate diazepam according to the required effect. What is the dose we choose? 5 to 10 milligram IV every 10 minutes till the sedation effect is obtained, or lorazepam, which is hepatic safe. Start at a dose of 2 to 4 milligram IV every 15 to 20 minutes. Or you can also choose to start lorazepam infusion 1 to 4 milligram per hour IV, titration to sedation target. Midazolam can also be used 2 to 4 milligram IV or IM or infusion for refractory cases. You can take a screenshot of this slide so you can use it in clinical settings. Initially, instead of the symptom-based therapy, a fixed dose regimen was used. The problem with the fixed dose regimen was you required a higher dose of benzodiazepine and the treatment duration was also prolonged, which led to unnecessary airway protection and prolonged sedation. So that is why we have switched to this symptom-based benzodiazepine treatment where we target the sedation level and adjust the benzodiazepines accordingly. In case of severe withdrawal, if diazepam is unavailable, what would you do? If the patient is severely agitated and the SIVAR scoring is more than 16 or the agitation scale is more than or equal to 3, see if the patient is able to take oral medications. If he is able to take oral medications, start with chlordiazepoxide, commonly known as Librium, at a dose of 25 to 100 milligram per oral. Repeat every hour until sedation target is met. If the patient is still not sedated, initiate a dose of injection midazolam 2 to 5 milligram IV for a single dose. If the patient is unable to take oral medications, start with injection midazolam 2 to 5 milligram IV every 5 minutes for 3 doses, then double the dose for the next 5 minutes until the symptoms are controlled. If the symptoms are controlled, then switch to lorazepam 2 to 4 milligram IV every 30 minutes, or you can start a lorazepam infusion at a rate of 1 to 4 milligram per hour. The comparison of dose, onset, and peak level of all the benzodiazepines that we commonly use in the emergency department is given in the slide. You can refer it later. If the symptoms are still not settled, even after continuing multiple benzodiazepines, you've almost given 1000 milligram to 2000 milligram of midazolam, lorazepam, then you have to think about another drug which is going to help you when there is so much of GABA receptor deficit. That is phenobarbital. Phenobarbital is also a GABA agonist, which will help you in achieving the sedation effect along with the benzodiazepine. So when it comes to refractory alcohol withdrawal syndrome, add phenobarbital along with the benzodiazepine infusion. If the patient is still having uncontrolled symptoms, prepare for a mechanical airway and intubate. Start the patient on propofol infusion, 25 mics per kg per minute. Propofol is also a GABA agonist, which will also help you to attain the desired sedation. As I told earlier, phenobarbital is also a GABA agonist, which has a very long half-life and will help you to attain the desired effect along with benzodiazepine. The loading dose is 10 milligram per kilogram, ideal body weight, IV, once infused over 30 minutes. The patient would require a low threshold for airway protection and requires an ICU setting. Amongst all the ethanol-related withdrawal and the syndromes, the most dangerous of them all is the delirium tremens, which has a high mortality of up to 15%. In case of delirium tremens, you have to remember the three symptoms, that is the triad of DHA. D for disorientation, H for hallucinations, and A for autonomic storm. Mostly the delirium tremens presents 1 to 2 to 3 days after the last drink. That is a key history that you can obtain from the patient. How do you manage delirium tremens? It is same as you treated the severe alcohol withdrawal with high dose IV benzodiazepines. You have to reassess the patient often, switch to an ICU level monitoring. If the patient is refractory, add phenobarbital 10 milligram per kilogram, ideal body weight, over 30 minutes. You can also add dexmedetomidine. Dexmedetomidine is not to control the withdrawal. It is only to suppress the autonomic storm. Make sure you do not add any antipsychotics alone because it lowers the seizure threshold. If you want to add antipsychotics, it can be given along with the benzodiazepines. Alcoholic ketoacidosis. How is it different from the classic diabetic ketoacidosis? It is not much different. The presentation and the pattern has a lot of similarity that you may be misguided in treating the alcoholic ketoacidosis as decay. The patient will have a history of poor oral intake, recent binge, then he would have stopped. Patient would have had multiple episodes of vomiting, abdominal pain. On blood gas analysis, you would get a high anion gap metabolic acidosis. But the key differentiating feature here is glucose levels would be normal or low. How would you manage alcoholic ketoacidosis? In AKA, the primary reason for ketosis is the depletion of glycogen stores and ketosis set in. So you supplement it, manage first with IV dextrose, preferably 5% thiamine before or with dextrose. Thiamine is a very important cofactor of the Krebs cycle. Only if you give thiamine, the dextrose you are supplementing would be utilized by the body, otherwise it is of no use. IV fluids for volume depletion and no insulin at all, and make sure you do not treat alcohol ketoacidosis at TKA. Wernicke's encephalopathy. Treat first and confirm later. Even though there is a triad of confusion, ataxia, ophthalmoplegia, the triad rarely exists. You cannot sit and wait for the triad to come so that you can treat the patient. If you have any kind of doubt, start the patient on IV thiamine 200 to 500 milligram before or with any glucose containing fluid in all patients at risk, even without the full triad. Please keep this in mind. This is the most important learning point regarding withdrawal and ethanol-related disorders. ED management of ethanol-related toxicology at a glance. Simple intoxication, supportive care, monitor airway, serial reassessment. In case of withdrawal, as we discussed, symptom-triggered benzodiazepines, CIVAR guided if possible. Delirium tremens, high-dose IV benzodiazepines, ICU, and phenobarbital 10 milligram per kg loading dose of ideal body weight. Alcohol ketoacidosis, dextrose, thiamine, fluids, and avoid insulin. Wernicke's encephalopathy, empiric high-dose IV thiamine, and do not wait for the triad. Let's look at another case. A 38-year-old man presents intoxicated appearing after reportedly drinking homemade spirits at a party the night before. He complains of blurry vision and abdominal pain. No alcohol odor is detected on his breath. Labs reveal a severe high anion gap metabolic acidosis. Labs reveal a severe high anion gap acidosis. Vital signs, heart rate is 110 per minute, BP is 138 by 82, respiratory rate is 26, saturating at 98% room air, pH is 7.02, bicarb is 6, anion gap is 32. What is the most likely diagnosis here? And what's your immediate first-line treatment? Yes, it's methanol poisoning, the toxic alcohol that steals vision. The minute you hear about homemade alcohol, odorless alcohol, visual disturbances, windshield washer fluid, the first differential on your list should be methanol toxicity. It is rapidly absorbed orally and can also be absorbed dermally or can be inhaled. The peak levels around 30 to 60 minutes after ingestion. The key point here is methanol itself is a minimally toxic parent compound. The toxicity is happening because of its toxic metabolites. Methanol is converted into formaldehyde via alcohol dehydrogenase, and formaldehyde gets converted into its toxic metabolite, which is formic acid, by aldehyde dehydrogenase. Formic acid causes both the metabolic acidosis and the direct retinal and optic nerve toxicity seen in methanol poisoning. Why is this metabolic cycle important? You have to understand that methanol poisoning, the rate-limiting enzyme here is the alcohol dehydrogenase. The formimazole and ethanol, which are the antidotes here, competitively blocks the alcohol dehydrogenase, which is the first enzyme in the pathway, and blocks the conversion of all the methanol to formic acid, thereby halting the toxic metabolite formation. How does the toxicity occur? Formic acid, the toxic metabolite here, inhibits the mitochondrial cytochrome C oxidase. Retina and optic nerve is highly metabolically active. Thereby, when the formic acid inhibits mitochondrial cytochrome C oxidase, it causes damage to the retina and the optic nerve. It causes optic disc edema, it causes retinal edema and axonal injury. Can even progress to permanent blindness if the patient is untreated. Clinical presentation of methanol poisoning. Initial stages, that is 0 to 6 hours, the patient can be in a latent phase. can have mild inebriation. Patient usually appears well. Formic acid is not yet accumulated, and there is not much of acidosis there. In 6 to 24 hours, that is the metabolic phase, patients would have nausea, vomiting, abdominal pain, headache, and acidosis starts to develop. More than 24 hours later, it is the severe phase where the visual disturbances, seizures, coma, and the cardiovascular collapse appears. Keep in mind that if a patient appears well, it does not mean there is no methanol poisoning. It is just that the patient is in its latent phase. One important concept that you have to understand when you learn about toxic alcohols is the concept of osmolar gap and anion gap. What is osmolar gap? Osmolar gap is the difference between the measured osmolality and the calculated osmolality. Osmolality can be calculated by the equation provided here, or you can use the online calculators which you have in your phone. The normal level is usually considered as 10 to 15 milliosmoles per kg. If it is elevated, it is termed as a high osmolar gap. Methanol being an osmotically active compound, it increases the measured osmolality, whereas we do not use methanol in the equation. So we get a lower calculated osmolality, which gives us a higher osmolar gap. So in methanol poisoning, we get a higher osmolar gap. In case of anion gap, it is the level of unmeasured anions. Formic acid, which is the toxic metabolite of methanol, gets converted into H plus and formate anion. This formate anion increases the anion gap, making it a high anion gap metabolic acidosis. Let's see why this is important. In the initial hours of ingestion, when methanol has not yet started to get converted into formic acid, the osmolar gap is high because the methanol level is high, which is a osmotically active compound. The osmolar gap comes down as the conversion happens. And as the conversion happens, if you focus on the graph here, as the conversion happens, formate anion increases, thereby increasing the anion gap. So in the initial phases, osmolar gap is higher, and when the conversion happens, osmolar gap comes down and the formate molecule increases the anion gap. So in the early phases, you have a high osmolar gap with a low anion gap. In the later phases, you have a high anion gap with a low osmolar gap. Is this concept thorough? I hope everybody has understood. This is the mainstay of diagnosis for all the toxic alcohol ingestion. The point at which this crossover occurs is the crossover point. The very favorite Viva question for all the exams. I hope osmolar gap and anion gap you guys have understood. So what is the clinical inference from this? Elevated osmolar gap plus a normal anion gap indicates an early toxic alcohol ingestion. It can be methanol, it can be ethylene glycol. Elevated anion gap with normal osmolar gap indicates a later stage, actively metabolizing stage. Excuse me. A normal osmolar gap does not exclude poisoning, especially if the patient is having a delayed presentation. The osmolar gap would have closed because most of the methanol has converted into formic acid. What are the laboratory abnormalities that we see? Severe high anion gap metabolic acidosis because of formic acid accumulation, elevated osmolar gap earlier in the presentation. Osmolar gap normalizes as anion gap widens. This is the classic crossover pattern. Lactate may be falsely elevated because formic acid interferes with some assays. Methanol level directly confirms diagnosis if it is available, but do not wait for the levels. If you have doubts, start with the treatment. Diagnostic approach, as we discussed, based on history, if you have suspicion, start the treatment. Get the blood gas analysis, get the methanol levels, do a fundoscopic exam, and visual acuity if there is any visual complaints. Antidotes for methanol poisoning. Formipizole and ethanol infusion. We have discussed earlier how they work. Formipizole and ethanol competitively blocks the alcohol dehydrogenase in the pathway where methanol gets converted into formic acid. Fomepizole, even though it is preferred, it is not available in India in most of the hospitals. Let's just learn the dosage for exam purposes. Loading dose is 15 milligram per kilogram IV, then 10 milligram per kilogram IV for 12 Tali doses for 4 doses, followed by 15 milligram per kilogram IV for 12 hours until the levels of methanol is less than 20 milligram per deciliter or the patient is asymptomatic. You have to increase the frequency of fomepizole administration to 4 hourly during dialysis. So the antidote that is available in most of the hospitals in India is ethanol, that is 10% ethanol. We do not have 10% ethanol directly. We have 100% absolute alcohol. You dilute it with normal saline or 5% dextrose and make it 10%. The loading dose is 7.5 to 10 ml per kg over 30 to 60 minutes, or per oral loading dose is also given if IV is unavailable. Maintenance infusion of about 1 to 2 ml per kg per hour IV. Titrate to serum ethanol levels of 100 to 150 milligram per deciliter. The problem with ethanol infusion is that you require frequent monitoring, and the activity is far less predictable than fomepizole. So you have treated the conversion of methanol to formic acid now. But what would you do with the formic acid which is already present before you started the treatment? That is why you have adjunctive therapy. In adjunctive therapy, you start with sodium bicarbonate, give it at a dose of 1 to 2 milliequivalents per kg, IV bolus, then infusion to correct the pH. Why do you need to do it? Sodium bicarbonate will increase the pH and thus preventing formic acid from penetrating the CNS and preventing all the symptoms from appearing. You can also use folinic acid or folic acid. Folinic acid is an important cofactor in accelerating the formic acid conversion to carbon dioxide and water. So sodium bicarbonate and folinic acid. In case of an unavailability of folinic acid, you can use folic acid. It is used at a dose of, started at a dose of 1 milligram per kg every 4th hourly. Indications for hemodialysis according to EXTRIP: severe metabolic acidosis, pH of less than or equal to 7.15, or persistent acidemia despite bicarbonate therapy, visual abnormalities or other end organ toxicity, renal failure, methanol levels more than 70 milligram per deciliter, deteriorating vital signs despite supportive care. Do not target osmolar gap for hemodialysis. That is never an indication. If any of the above mentioned points are there, you can start the patient on hemodialysis. Even if the patient is started on hemodialysis, make sure to continue fomepizole and increase the frequency of fomepizole. Dialysis would remove both the toxin and the antidote from it. Summarizing it together, if there is a suspected methanol poisoning, calculate the anion gap, osmolar gap, and get the blood gas analysis immediately. If there is high suspicion, that is acidosis, elevated gaps, visual disturbances, and compatible history, start the patient on fomepizole. Do not wait for methanol levels. Adjunctive therapy of bicarbonate and folinic acid is also added. If the patient meets EXTRIP criteria, start the patient on dialysis. If visual symptoms are present, do not hesitate to start treatment for methanol poisoning. Absence of acidosis does not exclude early poisoning. Patient can still be in the latent phase. So going back to our case, the presentation was classic for methanol poisoning. Patient had visual symptoms and severe high anion gap metabolic acidosis. He did not have an alcohol odor, which was a clue. Methanol and ethylene glycol are relatively odorless. The anion gap was 32 and osmolar gap has to be calculated there. Start fomepizole immediately. Do not wait for confirmatory methanol level. The pH is 7.02. It meets EXTRIP criteria for dialysis. Add sodium bicarbonate and folinic acid as adjuncts. Keep in mind visual symptoms. With severe acidosis, a compatible ingestion history is enough to start antidote therapy immediately. Moving on to the next case. A 45-year-old man is brought in by his wife for slurred speech and unsteady gait, found in the garage after working on his car. He appears intoxicated, but there is no smell of alcohol on his breath. He complains of nausea and mild abdominal discomfort. Several hours later, he becomes tachypnic and labs return a severe high anion gap acidosis with a low serum calcium. Vital signs: heart rate of 116, BP of 128/78, respiratory rate of 28 per minute. He's saturating at 97% room air. pH is 7.08, bicarb is 8, anion gap is 30, calcium is 7.2. What is the most likely diagnosis and what's your immediate first line treatment? Yes, it's a case of ethylene glycol poisoning, the toxic alcohol that destroys the kidneys. As similar to methanol, it is an odorless alcohol, but the distinctive feature here is it has a very sweet taste, which increases the risk for pediatric and intentional ingestion. It is seen in automotive antifreeze, engine coolants, brake fluids, and some hydraulic fluids. It is rapidly absorbed orally, peak levels within 1 to 4 hours. It is metabolized in the liver primarily by the alcohol dehydrogenase. The mechanism is almost as same as methanol. The parent compound is minimally toxic. It is converted into glycolic acid by alcohol dehydrogenase, and aldehyde dehydrogenase converts into oxalic acid. This oxalic acid combines with the calcium to form oxalate crystal to produce all the symptoms. The antidote logic is the same as in methanol, that is fomepizole and ethanol competitively blocks the alcohol dehydrogenase, preventing the conversion to oxalic acid. The clinical stages of ethylene glycol poisoning. First stage is the initial stage, appears at 30 minutes to 12 hours, the neurological state. Patient appears inebriated without alcohol odor. That is the distinguishing feature, without alcohol odor, ataxia, nausea, CNS depression, and possibly seizures. The second phase is the cardiopulmonary phase. 12 to 24 hours after ingestion, patient has tachycardia, hypertension, tachypnea, and pulmonary edema. The third stage is the renal stage, appears after 24 to 72 hours of ingestion, acute kidney injury, flank pain, oliguria, calcium oxalate crystalluria. How does the renal toxicity occur? The oxalic acid, which is the metabolite of ethylene glycol, binds with the calcium and forms calcium oxalate crystals. The crystal precipitates in the renal tubules and directly causes tubular injury and can cause acute tubular necrosis leading to anuric or oliguric renal failure. The concurrent hypocalcemia can also lead to tetany and QT prolongation, thereby arrhythmias. You can also see on urine microscopy that there are envelope-shaped or needle-shaped crystals. The laboratory findings in ethylene glycol poisoning are high anion gap metabolic acidosis due to oxalic and glycolic acid, elevated osmolar gap early, as we discussed earlier in methanol poisoning. As ethylene glycol is a osmotically active component, it increases the osmolar gap, but once it starts converting into glycolic acid and oxalic acid, the osmolar gap comes down and the anion gap goes up. The same crossover pattern appears here also. Hypocalcemia is seen with calcium oxalate formation. Calcium oxalate crystals are seen on urine analysis. Ethylene glycol levels will confirm the diagnosis, but do not wait for the results. The urine crystals are not used as a diagnostic feature. It can be just used as a marker. How do you use the antidote? The antidote dosage is same as that in methanol. You start fomepizole at a dose of 15 milligram per kilogram IV loading, followed by 10 milligram per kilogram IV every 12th hourly for 4 doses, then 15 milligram per kilogram IV 12th hourly until the level is less than 20 milligram. If you are initiating hemodialysis, increase the frequency to 4th hourly. Here, the same concept of starting soda bicarbonate is here. 1 to 2 milliequivalents per kilogram IV bolus, then infusion of the same to correct pH. This is to correct the acidosis and to prevent penetration of the acidic compound. Thiamine is initiated 100 milligram IV daily because it is an important cofactor and shunts the glycolic acid conversion from oxalic acid formation. And pyridoxine, which is given at a dose of 50 to 100 milligram IV daily, it is an important cofactor in converting glyoxylate into glycine. Both are non-toxic components, so the adjunctive therapy will reduce the already formed glycolic acid and oxalic acid from creating symptoms. The indications for dialysis: severe metabolic acidosis less than 7.1 to 7.15 or refractory acidemia, acute kidney injury or renal failure, deteriorating vital signs despite supportive therapy, ethylene glycol levels more than 50 milligram per deciliter, coma or seizures attributable to poisoning. Make sure to increase the frequency of fomepizole when you are initiating dialysis. Management algorithm: if you suspect ethylene glycol, calculate anion gap, osmolar gap, get a blood gas analysis, and calcium levels. If high suspicion is there, acidosis, high osmolar gap or high anion gap with no alcohol order with compatible history, start fomepizole immediately. Bicarbonate, thiamine, and pyridoxine as adjunctive therapy. Meets EXTRIP criteria, start hemodialysis along with fomepizole dose adjustment. Calcium oxalate crystals support the diagnosis, but their absence never excludes poisoning. Early antidote is the key to treatment. Never wait for the levels. This is a high yield comparison table of all the three toxic alcohols that we've discussed till now. You can take a screenshot of this. Ethanol, methanol, and ethylene glycol. The toxic metabolite of ethanol is acetaldehyde. Methanol is formic acid. Ethylene glycol is glycolic acid and oxalic acid. Signature feature of ethanol is intoxication. Methanol, visual toxicity and blindness. Ethylene glycol, renal failure, and the alcohol is odorless. Acid-base picture, ethanol does not have much of a differentiating acid-base picture. Methanol and ethylene glycol has a severe anion gap metabolic acidosis in the later phase. If it is in the earlier phase, there would be a higher osmolar gap. Antidotes for ethanol intoxication is supportive care and according to the symptoms that is presenting. Methanol, the antidote is fomepizole or ethanol. The same goes for ethylene glycol. Dialysis is rarely needed for ethanol, methanol and ethylene glycol as per EXTRIP criteria. These are the few things that I want you to take away from this lecture. Treat vital signs derangement, not the label intoxicated. Don't treat a patient as just drunk. Check glucose, core temperature, and gaps before anything else. Thiamine 200 to 500 milligram IV before or with glucose in all at-risk patients. Symptom-triggered benzodiazepines beat fixed dose withdrawal protocols. Don't wait for the full Wernicke's triad to treat. A normal osmolar gap does not exclude toxic alcohol poisoning. The patient would be in a delayed presentation. Visual symptoms plus compatible history. Treat as methanol until proven otherwise. No alcohol order plus intoxicated appearance, suspect ethylene glycol. Start fomepizole on suspicion or if not available, 10% alcohol. Never wait for a confirmatory level. Dialysis clears the antidote too. So increase the fomepizole frequency to 4th hourly during HT. This is the key dosing summary. All the drugs that you have to use in case of toxic alcohol ingestion: thiamine, diazepam, lorazepam infusion, phenobarbital loading dose, fomepizole loading dose, ethanol infusion, folic acid or folinic acid, and thiamine and pyridoxine. The final take-home message: alcohol toxicology spans a true spectrum, from benign intoxication to fatal delirium tremens and toxic alcohol poisoning. Never anchor on just drunk. Glucose, trauma, and toxic co-ingestion are frequently missed. Benzodiazepines remain the cornerstone of withdrawal management, with phenobarbital as a proven adjunct. In toxic alcohol poisoning, speed of recognition and antidote administration directly prevents permanent harm. So as we discussed, I want you all to answer the 3 questions. Which is the alcohol involved? What appropriate treatment to start? And when to escalate management? Thank you. Over to you, Dr. Vaishak.
That was a great session. Clinically based scenarios we had. We know alcohol is a very vast topic that we have in our textbooks, but you have taken much effort to concise it down. And with the clinically based scenarios, that was very nice to hear. Hope everyone enjoyed the session, got how to manage toxic alcohols in your emergency department. If you have any further doubts, you can ask in our groups. We are already there to help you. And thank you, Dr. Nadeeja, for the session. Hope you all see in another session. Thank you.